Good afternoon, all doctors. On behalf of Science Integra and Sun Pharma, I welcome you all. Artist FIGO NCD Committee and RCOG IRC India South Zone presents the TOG webinar on pregnancy to NCD opportunities for prevention. Today we have esteemed faculties, both national as well as international, who will be sharing their clinical experiences on the topic. To begin with, I am privileged to introduce Dr. Uma Ram. Dr. Uma Ram is the Director and Consultant Obstetrics and Gynecologist at Sitapati Clinic and Hospital, Chennai. She is the Chairperson, South Zone AICCC RCOG, Examiner Part 3 MRCOG. She has received several awards like the Young Gynecologist Award 2007, AOFOG, IDF Blue Ring, Women Achiever Award, Rotary International 2015. Her areas of interest are fetal growth, multiple pregnancy and fetoscopy. And of course, her hobbies are music, reading, and travel. I welcome Dr. Uma Ram and request her to please go ahead with the proceedings for today's meeting. Thank you.
Thank you very much, Meenan. Welcome everybody to this session on a very important topic focusing on pregnancy, adverse pregnancy outcomes, and long-term morbidity. As obstetricians, we have for the longest time focused on pregnancy with the intention of ensuring that we have a happy mother and a healthy baby. But in the last decade, we have understood that the impact of pregnancy goes beyond that moment when we hand over the baby to the mother, and that pregnancy is an excellent window of opportunity for actually preventing future non-communicable diseases. And there are women who have adverse pregnancy outcomes who are at significant increased risk of developing NCD. And especially in India, where the burden of NCDs is huge, it is important that this area receives as much attention and as much enthusiasm and buy-in from obstetricians, because we are in a unique position to actually work towards prevention. So last year when we had this meeting, the South Zone RCOG annual meeting with LATHA VENKATARAM in Bangalore, we focused entirely on this aspect, and we were very privileged to have the launch of the Pony initiative there. And so I'm very, very happy that we are having this webinar. I am delighted that Dr. Hema Divakar is chairing this session as a convener. Hema, as we all know, is a very enthusiastic, committed obstetrician. She has gone on various posts within FOXY, ultimately being the president in 2013. She's currently the co-chair of the FIGO GDM committee and the pregnancy NCD group of FIGO. And it is her enthusiasm and focus to spread this message and carry this forward to everybody. I am extremely happy to have with me as a co-chair Dr. BHASKAR Pal. BHASKAR is a good friend. He's a senior consultant gynecologist at Apollo, Kolkata. He is the chairperson of AICC RCOG East Zone and the chair elect for All India AICC RCOG. And he's the FOXY representative to SUFOG for the year 2014 and 2021-23. And he's always been a very active figure in all aspects, and I'm very, very happy that he's here to support this program. And I'm extremely happy to have SUCHITRA with us. SUCHITRA PANDIT is again an extremely dynamic obstetrician, somebody that we all know who has had also multiple roles driving many initiatives in an individual capacity and in her capacity within FOXI. She has been the past president of FOXI. She is the president of ISOPAB currently and of organization Gestosis. She has been the FOXI's representative to AOFOG and the chair of the SAFOG Medical Education Committee 2017 to 18. She's currently the chairperson of the AICC RCOG All India. So I'm extremely happy that Suchitra is here, and I request her as the guest of honor to say a few words, and then we move on with the rest of the program. Thank you, Suchi.
Thank you, Uma. Thank you, first of all, for organizing this very, very important webinar. And as AICC chair, obviously, I'd like to be involved in all the zonal activities, but it's kind of you to let me speak before the main speakers. But thank you very much for this opportunity. We all understand that NCDs, non-communicable diseases, are such an important aspect of our women, and that is, the problems are causing almost 70% of global mortality. We understand that cancer, cardiovascular problems, or COPDs, hyperglycemia in pregnancy, hypertension, and all the mental neurological problems, they cause so much of morbidity. So it's important that we create a general awareness amongst the obstetricians and gynecologists, and we get them to have a preventive approach, because we understand that maternal and child health, it's in very, very closely linked to all these problems. And if we look at the preventive aspects, I think that'll be go a very, very long way forward. So I've seen all your faculty. You've got very eminent gynecologists, as well as we've got a nutritionist who's going to be, debating and giving us some very important points. And I'm happy to welcome Professor David McIntyre, head of the maternal clinical unit. He's going to be formally introduced, but lovely to see you, Professor David, because, your talk is going to also throw a lot of, inputs. It's going to give us a lot of information, and we're really looking forward to this. And once again, Uma, I'd like to congratulate you for taking up this particular subject in your webinar, and good luck. And I'm sure the viewers are really going to be benefited with this particular information. And Hema, as ever, the dynamic, cheerful, chirpy self. So it's wonderful that she is a co-chair of the FIGO and has brought about so many changes. And congratulations to her also for taking this particular initiative forward. Thank you very much. And over to you, Uma.
On behalf of Uma and myself, I sincerely thank Dr. Suchitra, who is at the helm of affairs of the RCOG Indian contingent. And we're really very, very proud of her position and the way she connects and executes a number of programs, not only in the 4 zones, which are structurally, organizationally, officially, the AICC RCOG in various zones, with Uma on the lead for the South Zone, and we were going to meet face to face at Kochi, next month if all would have gone well. But we always have the plan B. We are continuing to be optimistic, and we said we will connect and collaborate in whichever manner that's possible. And that's what, ladies and gentlemen, brings us together with what we call as East meets the West. And apart from the very distinguished national faculty that we have with us, we are privileged to welcome 2 of our overseas faculty, Dr. Saravanan and Dr. David McIntyre, who is my very beloved friend and colleague. And we have been in the thick of execution of a variety of initiatives, getting together with what we call the PNCD, Pregnancy and NCD Committee of FIGO, and he has been a real asset and a value add to that committee. More importantly, his maturity and his patience to listen to those from the low middle income countries like ourselves, who place our difficulties, our problems Most of the faculty from RCOG who are Indians who are here today have trained abroad, and I'm sure they can see a stark difference between the nature of practice there and the ground realities in our country. And we need some people like Sarah David to speak and amplify our concerns to the rest of the world. And when we say FIGO is the global voice for women's health, then thank you, Sarah and David, for your solidarity and support, as always, to make our voices heard on the international platform. Coming back to David's introduction, I said Plan B. Why the Plan B? David is here live with us, but still, we thought the corona pandemic has taught us always keep your options ready. So we requested him for a pre-recorded talk of 25 minutes on the very topic of how this COVID-19 pandemic has influenced our thinking, especially with respect to the GDM. David is going to be speaking about his official position and what he is doing in the introductory part of his pre-recorded piece that he has so kindly sent us a few days ago. But we were all very, very proud in the year 2016 when David became the first Australian trained clinician to receive the Norbert Frankel Award contribution to diabetes in pregnancy from the American Diabetes Association. From 2017 to 19, he has developed a collaborative research in Denmark as a visiting professor for the Danish Diabetes Academy. He was also awarded the Jorgen Medicine Lecture and Medal by the DPSG, the Diabetes Pregnancy Study Group of Europe. DPSG, our own home study group led by Pishaya. Pishaya and David go a long way together in history of women, diabetes, obesity, pregnancy, hypertension, and the related issues. And the Women in Diabetes stream led award lecture at the International Diabetes Federation. Those of us who were there in 2019, he was kind enough and humble enough to seek a slide or two from each one of us to actually tell what is happening around the globe. So indeed, apart from the formal introduction, there's much more to David McIntyre, whom I know and whom the NCD committee knows. So it is indeed a very, very great pleasure, ladies and gentlemen, to present to you David, who will speak on COVID, AGDM, and more. Over to you, David. David is available for the live Q&A as well. David, if you want to speak to our audience after unmuting just before we play your recorded piece. Yes. Thank you.
Really appreciate the opportunity to be here and those very kind introductions. And yeah, I decided that the talk would be interesting on the topic of COVID-19, obviously very topical all around the world, and a lot of different responses have been made by different countries relating to pregnancy care, and in particular, a number related to GDM. So the idea of my talk is to put those changes into perspective with what they might mean for lack of opportunities generally to detect NCDs. And as you know, in India, Dipsy and other colleagues and Foxy have also come out with a position statement, which I mentioned briefly, but I'll let to other people who are probably more familiar with it to talk about it in the discussion. So thanks very much for your attention. And yes, the actual presentation is pre-recorded just to be on the safe side, and then hopefully we'll have some discussion later. So thank you all very much.
Thank you. Subbu and team. Give a go ahead. Yeah.
Yeah, madam.
Hello, my name is David McIntyre and I'm a Professor of Medicine and Endocrinology at the University of Queensland in Brisbane, Australia, and I work clinically both as an endocrinologist and in medical disorders of pregnancy or obstetric medicine. And I'm very happy today to share with you some thoughts and recent publications regarding the approach to both the diagnosis and treatment of gestational diabetes mellitus during the context of the current COVID-19 global pandemic. Now, as we know, both COVID-19 and GDM are quite common right around the world, and today we're speaking specifically of India, which unfortunately has a high prevalence both of COVID infections and also of all types of diabetes, including gestational diabetes. We also know that in this space, information is rapidly changing and that things are really happening and changing in the COVID space over the course of weeks, sometimes even over the course of days. So some of the other questions are much slower to evolve in the background. For instance, how we deal with non-communicable diseases in general and GDM in particular in the context of this very rapidly changing epidemic. So we have issues regarding COVID-19 in general and pregnancy care. We have also the specific features of the usual diagnostic test for GDM, which is the oral glucose tolerance test, which represents a 2 to 3 hour test in the midst of a pandemic, which may not be the easiest or most practical solution. And so for a number of places, there have been suggested changes in testing and alternative means of detecting women with hyperglycemia in pregnancy so as to avoid excess risk of COVID-19 exposure. We have the question of allocation of healthcare resources, both for GDM testing and also for treatment and therapy. And we have multiple changes in care that have happened in terms of telehealth, telephone consultations, in terms of how we best provide postnatal follow-up and postnatal care. And then we also have this problem of the relative value or perceived value of what is an acute infectious disease crisis versus the long-term global burden and local burden of non-communicable diseases. And essentially we have a conflict and a contrast between short and longer-term priorities. Now, in response to this, FIGO developed earlier this year, in the very early stages of the pandemic, some interim guidelines for people dealing with COVID-19 cases, and was based largely on experience from centres with early exposure to COVID-19, such as some of those in China and Italy, and focused really on the immediate major problems of COVID in pregnancy, and in fact at that time recommended no particular changes to gestational diabetes diagnostic pathways. Subsequently, however, we've noted that the FIGO process is actually quite different from one country to another, and you would be familiar with the Indian process, which involves the DIPSI test, either a fasting or a non-fasting 2-hour glucose tolerance test, in general with only the 2-hour glucose value considered in the diagnostic algorithm, and a 2-hour glucose between 7.8 and 11.0 millimoles per litre being considered as GDM, values lower than that being considered normal, and values higher than that being considered as consistent with overt diabetes. So this has certainly been acknowledged by FIGO as one option for diagnosis of GDM, and one that seems particularly appropriate to the Indian situation. However, many other countries made early recommendations regarding changes or suggested changes to the method of GDM diagnosis. Now, the United Kingdom has only a risk factor-based approach to GDM testing, and that involved pre-COVID a 75-gram glucose tolerance test as the primary test. Post-COVID, they've also suggested using risk factors, but have tried to totally avoid glucose tolerance tests, replacing them with HbA1c and either a random or a fasting glucose. And you'll see these criteria listed in the right-hand column, which are quite common in some centres around the world, particularly with the HbA1c greater than or equal to 5.7%, which will be consistent with pre-diabetes outside pregnancy, also using the UK cutoff of 5.6 millimoles for fasting, and also including a random glucose option of greater than or equal to 9 millimoles per litre. Now, Canada does perform universal testing, but uses a 2-step process with a glucose challenge, followed by a glucose tolerance test for those who test positive on the challenge test. They again have decided in the COVID context to maintain universal testing, but to totally abandon glucose tolerance tests and instead to use hemoglobin A1C and random glucose. They've set their HbA1c cutoff the same point as that used in the UK, 5.7%, but they've really set a very high random glucose threshold, which in most places will be consistent with overt or undiagnosed type 2 diabetes of 11.1 millimoles per litre. Now, Australia has taken a different approach. Australia, in the pre-COVID context, used universal testing, with all women being recommended for a primary 75-gram full glucose tolerance test over 2 hours. Post-COVID, they have used a universal testing approach, but with the decision regarding glucose tolerance testing based on the fasting glucose value. So essentially the Australian approach has been to perform that fasting glucose, a value of greater than or equal to 5.1, considered consistent with GDM, a value less than 4.7, accepted as normal with no further testing, and so only those women with a fasting value in the range of 4.7 to 5.0 would require and proceed to a full glucose tolerance test. So we wish to examine this, the efficacy or the reality of these changes, and doing this using quite a large sub-cohort from the HARPO study of almost 6,000 women across a multi-ethnic background from the US, Hong Kong and Australia. And in these women, we had evidence of a full diagnostic glucose tolerance test between 28 and 32 weeks gestation. We also had hemoglobin A1C. The glucose values were blinded, and none of these women were treated for GDM. So we had the advantage of a non-treatment confounded cohort. And using this approach, we were able to compare the UK, Canadian and Australian approaches, both comparing the number of women who had GDM by various criteria, and also the number of outcomes in untreated women which would be missed with restricted COVID-based GDM testing protocols. So what we found in terms of GDM numbers, you'll see varies quite markedly between the three different environments. In the UK, they were considering about 12.9% of women as GDM in the pre-COVID setting. This decreased by about 80% to 2.5% in the post-COVID testing protocol. In Canada, you'll see the number of women they were detecting pre-COVID was much lower due to their higher diagnostic thresholds, and post-COVID, this also decreased by around 80%. In Australia, far more women were being classified as having GDM in the pre-COVID space, with a rate of around 17%, and that would decrease to 12.7% with the proposed Australian modification in diagnostic pathway in the context of the COVID epidemic. So in fact, in all cases, GDM numbers were lower using the post-COVID protocols, but the question then remains, what are the consequences, not just the numbers, but the consequences in terms of clinical outcomes? So we'll deal first with the United Kingdom before and after COVID, and you'll see we've looked at several outcomes: hypertension, preterm birth, large for gestational age, excess neonatal adiposity or fatness, and the rates of primary caesarean section. And those with post-COVID GDM, yes, they still have the highest rates of overall adverse outcomes, but those who are no longer being detected, that we've called missed GDMs, also still generally have substantially higher rates than seen in the non-GDM population. So we certainly managed to reduce the number of women with GDM, but we also miss a group of women who are still have substantially higher rates of complication than those with no GDM at all. And then to put this into a clear context, we've looked at the percentage of missed outcomes after COVID. So the outcome rates are shown in these two bars here, in the blue showing the missed GDMs, in the orange showing the women still diagnosed as GDM post-COVID. And in these red bars, we've shown how many of the GDM-related outcomes, which are the things we're trying to influence with our diagnosis and treatment, will actually be completely missed with the post-COVID protocol. And you'll see it in the UK that often is only around 50% for hypertension, but for the other outcomes, they're missing anything between 70 and 80% of the women who might otherwise receive intervention and receive benefit from that intervention in the post-COVID space. So there is certainly a cost in terms of chance to intervene that is being lost in this situation. Now, when we look at the Canadian suggestion, the same colours apply. So you'll see these are the non-GDM outcome rates. And you'll see that in the Canadian case, the post-COVID GDMs who are still detected and those who are entirely missed are really at almost the same risk of various adverse outcomes. So there's not much selection between those who remain GDM and those whose GDM is missed after the change in the COVID protocol. And this is very clear when you look at these red bars again. The percentage of outcomes missed is anywhere between 80 and 90%. So yes, they do effectively decrease GDM numbers by around 80%, but they also miss any chance of intervening in around 80% of cases where adverse outcomes may potentially result. Now, the Australian analysis is somewhat different. These, again, are the event rates in the non-GDM population. And you will see that, yes, those with post-COVID GDM do have higher risks of hypertension, preterm birth, LGA, neonatal adiposity and caesarean section. But in fact, those who are missed with the Australian protocol of limited GTTs have actually, in some cases, in fact, for hypertension, lower event rates than the non-GDMs. And for most others, for instance, the LGA rate is only just above 10%. The neonatal adiposity rate is also close to the expected 10%. So overall, it appears that these women who are missed with the Australian protocol are a lower risk group than those whose GDM is still detected. And if we look at this as a comparison between the number of outcomes that are actually missed, in contrast to the others where we were missing around 80%, we are missing only 10% of hypertensive disorders, 20% of preterm births, 15% of LGA. So the number of actual outcomes missed in the post-COVID testing protocol is much less using the Australian protocol. If we then compare this across the three countries and show what percentage of outcomes is missed in each context, we'll see that the highest number of missed outcomes comes in the Canadian context, still an elevated rate but somewhat less for the UK, and far less overall missed outcomes in the Australian context. So this represents the cost in terms of lack of intervention, which I think needs to be considered in the decision about GDM diagnosis, in addition just to the sheer weight of numbers of women with GDM. So a number of other countries since that time have come in with their own suggested protocols. These are in some ways similar. You'll see that Spain has also used a combination of HbA1c with a 5.7% cutoff, also suggested random glucose and fasting glucose as possible measures. Italy has decided to recommend a fasting glucose only based approach, also using risk factors and recommending diagnosis of GDM only on the criterion of greater than equal to 5.1 millimoles fasting. France has come up with a protocol of testing HbA1c and fasting glucose and using a cutoff of 5.7% for HbA1c and 5.1 millimoles per litre for fasting glucose. So all of these are somewhat different, but the 5.7% cutoff for HbA1c is fairly common. So interestingly, many places have also considered the question of early pregnancy testing after COVID-19, and despite the fact there is less evidence, there seems to be more agreement between different countries. So most countries are recommending only risk factor-based testing. They're using the conventional cutoff for HbA1c of 6.5% to diagnose diabetes in pregnancy, and they're mostly recommending an HbA1c range from 5.9 to 6.4% as equivalent to GDM diagnosis in early pregnancy. But some do also include the option of adding fasting or random glucose or even glucose tolerance testing. So just to compare those various tests, the 75-gram glucose tolerance test, I guess, is still the gold standard. If you shorten that to only a fasting and a 1-hour test, you'll miss about 12% of GDM diagnoses, but you have a shorter testing time. Now, a fasting glucose will have a much shorter testing time, but women still need to come in the early morning, and that will miss around 20 to 25% of GDM. But clearly, the number of women diagnosed or missed with fasting depends very much on the ethnic composition of your pregnant population, and particularly in Asian populations, particularly East Asians, but also in some studies South Asians, fasting glucose is less of a contributor to GDM diagnosis. Now, the hemoglobin A1C really performs very poorly. We'd all like it to work well, but it simply doesn't. It misses around 75% of GDM potential diagnoses, and there are a number of other issues such as red cell, lifespan, and hemoglobin abnormalities which make it a less useful test. A random glucose also has a short testing time, but is totally non-standardized and probably misses around about 30% if a 7.5 millimole per litre cutoff is used, and even more inaccuracies are potentially introduced by the use of home testing with a home meter. Some people have suggested that just a previous diagnosis of GDM in another pregnancy would be enough, but as we know, GDM recurrence is by no means 100%, varies between 30 to 70%, and varies again by ethnicity. And some people have also suggested to abandon the whole laboratory glucose testing process and use only self-tested home glucose levels, but then in this context we have no evidence, and essentially women with no GDM would be treated as GDM. Now, as you also probably know, because many of you are involved in this process, the Indian group have presented the DIPSI protocol during the COVID pandemic, and essentially this protocol, to summarise, is business as usual. They recommend the DIPSI 2-hour single test, 75-gram fasting or non-fasting test, unchanged cutoff of 7.8 millimoles per litre, and they also support the use of telehealth, online resources and webinars. They recommend the importance of persisting with postnatal glucose evaluation using a GTT with cutoffs of 5.6 millimoles and 7.8 millimoles being used conventionally. They also strongly recommend breastfeeding for 2 to 6 months. So what about care during pregnancy outside diagnosis? So worldwide, there has certainly been widespread adoption of digital health solutions, telehealth, telephone consultations. And again, this is a balance between the risk of COVID-19 exposure versus the risk of suboptimal care and women not actually receiving enough care and attention, potentially not receiving their ultrasound scans. So it's not just the diagnostic problem, it's the lack of care for other parts of GDM. So the other point is that to mitigate against some of these risks of clinic attendances or pathology testing attendances, there are other things we can do, including social distancing, hand washing, use of face masks or other personal protective equipment. These all remain important alternative measures. What about care after pregnancy? So certainly we know that postpartum follow-up and effective diabetes prevention are one of the major value adds to the clinical care of GDM. It's that life course perspective of preventing progression towards diabetes and other complications both in mother and baby. So no diagnosis means no opportunity for postpartum follow-up or intervention. So most of the national recommendations favour delaying formal postpartum glucose tolerance tests till after the pandemic, but I guess none of us know exactly when that might be. And clearly women who present with more severe hypoglycemia are thought likely to have type 1 or type 2 diabetes need to be identified and followed up appropriately in the early postpartum period. So the mode of follow-up, whether it should be HbA1c, fasting glucose, or even glucose tolerance tests remains to be determined. We know that glucose tolerance tests perform better in detecting glucose abnormalities in the early postnatal period, but it is as yet clear what is the best value with longer-term follow-up. And very few of the recommendations have formally considered the future health of the offspring of the woman with gestational diabetes. So the World Health Organization has produced a report on the impact of COVID on the care of non-communicable diseases in general, and they surveyed a number of places for 163 countries to provide a snapshot of what is actually happening in NCD care across the world in the context of the pandemic. And in this context, we need to remember that NCDs are by far the biggest contributor to overall mortality on a global level. So the blue bars in this graph represent the non-communicable diseases. You see that it's not just diabetes, also ischemic heart disease, stroke, and other conditions such as cancer that contribute a lot to global mortality, not just infectious diseases. And sadly, you'll see that what has actually happened, it is pretty clear that the more COVID spread there is with any particular community, the more that chronic health and NCD services has been disrupted. So if you look at diabetes, a disruption of around about 30% where there's only sporadic cases of COVID, and where there's large or widespread community spread, that increases to around 65% of disrupted care for diabetes in the context of the COVID epidemic. So there are then severe challenges in dealing with the relationship between COVID and NCDs. We clearly have urgent clinical needs for the COVID patients who need to be looked after here and now. As a result, we often have redeployment of staff from other areas which are thought to be of lesser priority. In some cases, clinics are actually closed and no longer providing services. There's disruption to public transport. In the early stages of the epidemic in particular, and even ongoing, there is a lack of personal protective equipment. In many places, screening programs of various sort for diabetes may have been curtailed or even stopped, and we have a lack of training facilities potentially for healthcare workers as people think of other priorities as being more important than NCD detection, treatment and prevention. And we also have some stock shortages of diagnostic materials and medications required to treat the burden of non-communicable diseases. So when we think about this in terms of women's health across the life course, I think we have to acknowledge that we only have this one time point during pregnancy to detect a woman as having GDM and then potentially influence her lifetime health trajectory. It's not something that we can just put off till after pregnancy and still detect in an effective fashion at that point. And also, baby's health and the offspring's health are important too. These are something that have received very little attention in the context of the arguments about treatment of GDM during COVID, but we need to think of both mother and baby in a long-term perspective and look after their health of both of those as best we can. So in summary then, we need to have a clear approach to GDM, and in fact these have been developed very rapidly, often empirically without any evidence. I don't doubt that everyone who has suggested changes has had the very best of intentions, but these have often been made very quickly in response to pressing demands and in the context of anxiety and fear for both the patients and the healthcare workers. So I think now it's time to take a step back and assess and reflect on the consequences of some of these ad hoc decisions, both in terms of diagnostic strategies and therapeutic strategies. And we need to really balance the current emergent effects and future health risks, particularly those related to non-diagnosis of GDM and the effects on mother and baby. And a separate thing that we need to consider is that although all the changes recommended so far have been suggested as only short-term in the context of the COVID pandemic, some of them may actually have some value in longer-term care and detection of diabetes. For instance, in the Australian situation, we're now looking at whether this lower risk group of women who have a fasting glucose in the low range, under 4.7 millimoles per litre, whether that may be a longer lasting change to our GDM diagnostic strategy as it allows us to target treatment more towards those women at higher risk of adverse outcomes. So overall then, we are still aiming for the right balance. We'd love to get rid of this terrible virus, but at the moment we have to deal with its effects, and it seems to be tipping the balance very much in its favour. However, in the longer term, we desperately need not to lose sight of the health of our mothers and babies, and we need to do the very best possible to guarantee the health of future generations. And with that, I'd like to thank you for your attention, and I'm happy to take any specific questions. And I'm also hoping we'll be able to discuss some of these issues in the panel discussion that will come a little bit later in this session.
Thank you so much, David. At the first glance, everybody in our country will agree that the constraint of access because of COVID pandemic, which the UK or Canada or Australia is facing at this moment, it is the same constraint of access that the women in India had even before the COVID pandemic. And that's why we had to work our head around doing something that is, feasible, not empirical. We tried to generate enough evidence around that. So if Bhaskar is here, Bhaskar, I may introduce him as one of our best brains from Bengal, BB, this Bhaskar. So he is in and out of the theatre, it looks like, but if Bhaskar is around, I would want him to make his comments, and also feel free to, because David is here for us. Bhaskar.
Hi, thank you. Thought-provoking talk. I think that the virus somehow seems to be a bit less. Am I audible?
Yes, Bhaskar.
Yeah, I think we've been lucky on two counts. The first count is that the COVID virus in India seems to be a bit less severe, and that is why I think most of our mothers who've been asymptomatic or very mildly symptomatic, we've lost, especially in the city of Calcutta, we've lost very few patients, very few mothers. Right? Means we can count them on our fingers how many we have or how many we've had severe disease. So we've been lucky on that count, and given the fact that as a country we've had a less than 2% mortality, patients are getting out of that panic stage that they will not get out of their homes or visit the hospitals. And the second count where we've been lucky is that the IT infrastructure and access to healthcare is even now relatively cheap. And while it is very difficult to get a 3-step GTT done in the context of the pandemic, this is where we've tried to optimize our antenatal care by trying to get all the blood tests done at one go. And that is where our DIPSI testing comes very useful. And also try and do the antenatal visits along with their ultrasounds to schedule that. And also teleconsultations or video consultations have taken a long way because you already had a very strong IT infrastructure. So I think it has been easier on us. In the month of April, when the disease was not so severe, when people were panicking, that is the time people actually, women miss their appointments. That is the time we've encountered a few women who had an IUGR which were late to diagnose, or we've had a few miscarriages, etc. But at the present moment, I think antenatal care has picked up, and we're lucky that it seems to be a bit of a less virulent virus, maybe because of the average age of the Indian population. But I think the take-home message is that we lose many more women, we lose many more mothers because of poor antenatal care, and we need to stop bypassing antenatal care because of COVID, because we lose very few mothers due to COVID, and we lose many more mothers because of preeclampsia and other disorders in pregnancy if the antenatal care goes unattended. Thank you, Hema.
Yeah, thank you, Bhaskar. I think I will invite comments from Suchitra as well before I take the audience questions, but I want to place on record the life course approach that David mentioned. Okay, the FIGO advice of doing the best that you can in the country context, as in the DIPSI test, is something that has helped us pick up more patients than what otherwise we would have done. And Saravanan's brilliant article in the Lancet, which said, don't miss this window of opportunity. Pregnancy is the time where you have your chance to do your best for both the mother and the future generation. So this is the context which I want all our audience to keep reminding themselves on, because don't miss the bus. And the way the other countries have quickly without evidence. So much has been talked about where is the evidence, where's the randomized control. But when the issue is burning and you got to do something, have changed gears with the perspective of do the best you can. And that's what we were doing in our country all the time. Suchitra.
Yeah. First of all, thank you very much, David. I think that was an extensive, like an overview over, what is exactly happening in all the other countries. And I do agree with Bhaskar. Fortunately for us, though the numbers of COVID seem huge, the pregnant women who are affected have had a fairly mild course of disease. And I agree. I mean, I would now thank Hema and Dipsy and Dr. Sheshaya for popularizing the Dipsy test. I mean, most of us are now, we've changed over to the Dipsy test. Now, what is my concern is, in the public sector, probably that window of opportunity is missed because the numbers are huge. At any antenatal clinic in a public hospital, you have between 200 to 300 antenatal patients. And today, because of the paucity of the PPE kits and paucity of the personnel, probably this particular time, the COVID time, I think we probably would have missed a lot of opportunities. And this particularly applies to detection of blood pressure as well as the, screening for the Dipsy test. However, having said that, we haven't got the proper statistics. We'll wait now for another couple of months and we should be able to get some data from the medical colleges. But I do agree with David that, this is such an important time. And if we miss this particular time, and for us in India, the NCDs, diabetes is high on the cards and hypertension is very high on the cards. And yes, I do agree that, not everybody would look at the mental health, but this is the time when the mental health does go through a change. And therefore, I think the viewers must understand that the message that he's given is very loud and clear. Don't miss this particular time. And Hema, I just wanted to tell you, many of us have been doing telemedicine this time because even pregnant patients don't want to come forward. Now it's a little better, but in the beginning when the pandemic started, they were very scared. So we had to do a teleconsult and get them to do the test. And quite often when we told them about the Dipsy test, they would go to the labs and the labs would say, oh, no, but you have to do the standard OGTT. So then we had to call up the labs and tell them, no, this is the method that we are following. So please just go ahead and do this. So thank you very much for your wonderful talk, David. Thank you.
Thank you, Suchitra. David, just a couple of quick questions from our audience. One question is from Dr. Jonas from overseas. It says Milton Keynes, or I can't recognize the geography, but the question is really good. The idea of changing the guidelines was for reducing the risk of COVID. What is the reduction in the risk of COVID by reducing the time that the women stay in the hospital? Do we have any evidence for that? Is it worth taking the risk of missing GDMs in the interest of COVID?
Well, look, I think that's a good question. As I mentioned, there are other things you can do. So a woman, has the whole 9 months of her pregnancy to be potentially at risk of getting COVID from anywhere from the local shop to her house, so it's not just the time she spends or doesn't spend having a pathology test done at a hospital or a clinic. So I think that's perhaps been a bit overdone. And it has been, I think, as one of your speakers was saying, driven by fear. I think at the beginning people were very worried. They saw hospitals again as a place for sick people, and they saw that as a place where they would be more likely to encounter COVID, so they didn't want to go there. But I think, some of these things have perhaps been a little bit overdone. I think the Australian response, I did outline the initial response, but in fact, Australia has had what we would call a traffic light response. So a green light is when COVID is low, just do normal testing. An orange light is really the protocol that I spoke about, where you might decide on the fasting. And a red light, if things got really bad, which fortunately they haven't really in Australia, would be perhaps just a fasting test or an HbA1c. So Australia has tried to come with a staged approach. And at the moment, most people are returning towards fairly normal testing. And I think that's probably a better response, honestly, than what the UK and Canada have done, both in terms of the fact that numbers are not as reduced and you're still picking up a large number of women with GDM. And the women that we are missing seem to be at lower risk. So I worry less about them.
I think deliberation of, how we change tracks and maneuver around whatever could be made available and see what the impact is. Here is a question, David, from Dr. Krishna Kumari from Hyderabad. Says, if you do the DIPSI testing, you're not doing the fasting. Okay. On missing the isolated fasting hyperglycemia, what is the impact on the fetus?
Well, it depends where you are, I think. I mean, because I think you've got to make a practical decision, and that's why I do support the DIPSI test, because I think in the Indian context, where women are often travelling large distances to get to an antenatal clinic, the idea that they would travel for several hours fasting just to have a glucose drink when they get there and feel sick and then have another test 2 hours later is not really practical at all. So I think that's very reasonable. I suspect that the fasting values are a bit different from different studies in India that I've seen. Some of the studies from Chennai suggest that fasting contributes very little, and you'll pick up almost everyone with the 2 hour of 7.8, which of course is a little bit, the 2 hour value you're using is actually a little bit lower than in some other countries. So you'll certainly pick up some that way. You'll probably miss a few, but in the end, I think you can't pick up every mild glucose abnormality. So I think in the Indian population, the fasting, depending on who you believe, is either important or less important. I think, for Chinese women, there's a lot less fasting hypoglycemia. East Asian women, I can say that definitely. For Arabic women or other Caucasians, there's a lot more fasting hypoglycemia, which is probably why that approach based on fasting first works better in a place like Australia. But for India, I think you probably have to stick with what's working already. And I think, as other people have said, the DIPSI test is a very practical alternative.
Yes, because Dr. Sirisha from Chennai says DIPSI guidelines did really help us a lot in simplifying the way we detect the gestational diabetes. There's Dr. Tyagi from Delhi who asks that here is a patient who is asymptomatic but COVID positive. Should you do the GTT for her in the standard method so that you are sure that you won't miss the hyperglycemia? Because she's anyway not undergone any other screening. So if we have that first opportunity, should you do that, or is HbA1c should be preferred, or what should you do in a known case of,
I think you could probably do your DIPSI test with appropriate protection, and then it's probably really protecting the staff and the other patients from the risk of transmission with use of face masks and use of isolation for the lady as she's having her test done. I mean, some places suggested that the person might wait outside or, after having their glucose load so they don't have a long time of exposure to other people in the pathology waiting room. I think practical measures to reduce the chance of exposure are important. And I wouldn't do no test at all, but I would do the same testing that you feel is validated in the rest of your population, which is the DIPSI test.
Right. There are a couple of questions from Mrs. Dr. Shashikala from Salem, for example, and Shanmugha from Tirunelveli. And these questions are related to the cutoffs and the use of metformin, etc., which I would, along with Uma, take during the panel discussion sessions, because it is more on the management part of it. And Dr. Lakshmi Kuti from Palakkad says, David, this topic was of a real practical importance. It has given us lots of insights into how things are changing in the backdrop of the COVID pandemic. So on behalf of all our viewers and of course our faculty, once again, David, for such a brilliant presentation, so insightful, and also making us feel that our intent of always doing the best that we can is the correct thing to do. Yeah,
I think so. We've got to remain positive and pragmatic, I think.
Yes. Thank you very much, David. Now I will hand over to Uma, who has lined up some very brilliant panel members and, of course, some very challenging cases. So when you guys are available, we will quiz you and get the best out of you for the benefit of a whole lot of audience from all over the world who are witnessing this program. Come on.
Okay, thank you very much. And we've had a very good start with this overview and lecture from Professor McIntyre. And now we move on to the panel discussion. And to join me in this panel, I have with with me the panelists. May I have their CVs, please? So I have with me Dr. Rekha Kurian. Rekha is a good friend. She is a senior consultant obstetrician at Joseph's Hospitals, Chennai. She was the vice president of FOXI and the past chair of the AICC RCOG Chennai. I also have the pleasure of having with us for discussion Professor Saravanan Ponnusamy. He is the professor of diabetes, endocrinology and metabolism from the University of Warwick. And his initial interest started with with thyroid disease but now I think a lot of his attention is on diabetes and programming of metabolic disorders. And he has 3 large trials that he is currently collating data on. And I've had the pleasure of collaborating with him on one of them. So welcome, Sarah. I also have the pleasure of having Shilpa Joshi. She's a much sought after dietitian, diabetes educator. She's the director of Mumbai Diet and Health Center, the vice president of the Indian Dietetic Association. And I think her contribution to this panel is going to be very vital and important. I have also with us Dr. JYOTI BHASKAR, senior consultant at the Apollo Cradle Hospital, Delhi. She is a very active obstetrician, not just in the RCOG forums, but as an executive member of NARCHI and heads of many committees. Welcome, Jyoti. And I also have with us Dr. LATHA Venkataraman, lead consultant at Rangadurai Memorial Hospital and the president of the Bangalore RCOG Trust, a very passionate and committed obstetrician who has been a source of encouragement for many. She's also very much involved with grassroots work, including development of an app for risk prediction that can be used in the community. So with this group of people who are going to help us navigate the cases, I move on to the panel discussion. And besides the panelists, I have, of course, my Hema Divakar with me, and she will be coordinating the panel with me, and Professor McIntyre for his expert comments as well. Now, we know that the burden of NCD is very large in India, and it is the WHO report of 2015 says that 5.8 million people die from NCDs in India. And if you look at the disability adjusted life years, it has grown from 30% in 1990 to about 55% in 2016. And the deaths due to NCD has increased from 37 to 61%. That's almost doubled in the same time. We all know and see on a day-to-day basis that we have the obesity malnutrition paradox in our population. We have a huge burden of gestational diabetes, nearly 1 in 5 women having gestational diabetes. And simply because of the large population that we have, even though the burden of hypertensive disorders is not that frequent in terms of numbers, it is quite large. Now, about 10 years ago, this came on the cover of the Time magazine, and since then, as obstetricians, we've had to kind of understand and engage with these concepts of DOHA, epigenetics, and microbiomes. And we all have always known pregnancy to be a period of change, and we would like to have a beautiful moment when we hand over a healthy baby to the healthy mother. But as I said in the beginning, as obstetricians, we need to understand that the influence of pregnancy goes beyond childbirth and affects the health of the mother and the baby. So we're going to have some case discussions that will focus on using pregnancy as a window of opportunity to impact health and disease across generations. And this is from the FIGO infographics. Actually, the FIGO infographics are always extremely well done. And this one is no different. And it talks about the challenge of pregnancy as an early life stress and the importance to use it as a point of intervention, especially with regard to long-term cardiovascular risk in these mothers. Starting with hypertensive disorders in pregnancy, we know that the most common cause of death from hypertensive disorders is stroke. And when we deal with women who have preeclampsia and eclampsia, we are worried about a lot of things. We're worried about pulmonary edema, abruption, aspiration, renal failure, hepatic failure, DIC, stroke. So this is there in the back of our minds when we take care of these women. And to begin with, I want to start with some very simple questions, and I'd like Rekha and Jyoti to set the ball rolling, and some quick answers on when do we initiate treatment in these women who present to us with hypertensive disorders. Let's say you have somebody who presents to you at say 24 weeks and or 26 weeks, and her blood pressure is 140/90. Are you going to initiate treatment? Rekha?
Yes, I think she's 24 weeks, and therefore we are thinking of pregnancy-induced hypertension or preeclampsia, and therefore at 140/90 we need to initiate treatment and put her under a follow-up so that she can, I mean, of course, you have to do the usual 2 readings, spaced, and then if it is still 140/90, I think it is important that we start initiating the treatment as well as the investigation to establish if it's preeclampsia. So 140/90 is the present cutoff. Earlier we used to say above 140/90, but equal to 140 or equal to 90 and above, we consider as hypertensive disorder, and we should start treatment and follow-up, very important for this patient.
Okay. Jyoti, would you agree, or do you have a different cutoff? I mean,
no, I would agree with the doctor.
100, because a lot of the initial guidances would suggest that we are not going to achieve anything by initiating antihypertensive therapy with a diastolic of 90.
Yes, definitely that was initially there, but with a lot of the maternal mortality reports which did come in UK, they themselves in the embrace have changed it now to 140/90. And the goal that we are trying to achieve over here, if we really talk about what is the goal, we want to bring it to 135/85. That is systolic 135 and the diastolic is going to be 85. But along with this, we also need to look into the other factors to be able to define whether it's just hypertension or it is also severe PET, that we look for the various other severe factors, which of course, I'm sure we'll be going to talk about that later. That is all the investigations to look at the various systems also that are involved in it.
Okay. And what would be your agent of choice when you're initiating therapy?
As far as I'm concerned, my agent of choice is going to be labetalol, and that's a drug that I use. And we're going to be starting somewhere from, depending on the blood pressure for the patient, from 100 twice a day to 200. And the maximum dose that I have gone to, the maximum would be approximately about 600 3 times. And then I change over to the next drug if that is not working onto it. Though logically it is said that you can use up to 2,400 milligrams per day. The first drug I would prefer to use is labetalol. Doesn't work, then I normally add to that is the nifedipine.
Okay. Rekha and LATHA, would you agree that labetalol will be your drug of choice? Or is there any?
Yeah. Yes. Earlier we used to have alpha-methyl dopa, but that's not so freely available now. And labetalol, we are all getting very comfortable with that over the past, say, 5 to 10 years. And that's the agent of choice. And it's given as a twice daily dosage. Generally start with 100 and then you can tailor it as Dr. Jyoti said.
Okay.
I think I would go up on the dosage up to 800 milligrams 3 times a day, and that's around 2,400. You might not see much effect with just 200 milligrams up to 3 times a day or twice a day. So that's the only thing that I would like to share.
Okay. So I think it is true that alpha-methyl dopa is no longer available for almost all of us. Labetalol is the first-line agent for the management. Now let's move on to a slightly different situation. Somebody who's booked with us, say from 14 weeks, and her booking weight was 81.7, her BMI was around 30. She had regular antenatal visits. She came in for her visit at 28 weeks when her blood pressure was 180/116, and the urine albumin as a dipstick done in the OP at that time was 3+. She had gained about 10.9 kilos since booking. So what would be your approach at this point? Jyoti?
So this particular patient, if you look at her blood pressure, 180/116 plus 3+ urine albumin. So she falls into PET with severe features. So such a patient has no role of an OPD treatment. She's the one I would like to admit her immediately into the hospital. Repeat her BB after 15 minutes of rest to see whether it still remains to be same and it is persistent. Immediately initiate all the investigations that we need to do. That is about complete CBC, her KFT, her LFT, her coagulation profile. And along with that, bring about steps to bring the BP down immediately. Because over here, I'm really worried to get her blood pressure down. So if it remains the same, then I would be next using antihypertensive drugs to be able to bring the BP down. And my main focus is going to be three things. First is to control the hypertension. Second, since she's in a severe features, to prevent development of any seizures in such a patient. And the third, of course, is to look at the baby and to really monitor the fetal baby. And then with the treatment to optimize the right time for the delivery of baby, if required, with the best results for both the mother and the baby.
Latha, what would be the antihypertensive that you would use now? We all agree that her blood pressure needs to be brought down.
Yes.
What would be the antihypertensive that you would use? And
I
what
would be happy to use IV levetolol, Uma.
Okay.
So that gives a smoother drop and control of blood pressure. And till you're happy with her, you can continue on IV levetolol. And also anticonvulsant treatment with magnesium sulfate would be initiated. That's what Dr. JYOTI mentioned. So IV levetolol, it's available. It's a bit expensive, there is no doubt. But oral levetolol, though the college nice guidelines say about oral levetolol, I'm still not very happy with it because it doesn't bring down the blood pressure very effectively, especially blood pressure of 180, 116. Yeah, I don't think it will bring it down easily.
I mean, the concern also with the use of difedipine is that sometimes the drop is unpredictable. And in any case, we need IV access because we need, this woman is not somebody that you can manage without an IV access. So, magnesium sulfate, we all agree that we would give for seizure prophylaxis. Now, Rekha, is there any role? Would you want to deliver this woman because this is severe preeclampsia? Obviously, you'll wait for her labs to come back. But is there any role for conservative management in this case?
Well, initially, as they all said, that I would first actually, in the OPD, we usually keep tablets of levetolol. We would actually first give levetolol orally and then transfer her up to the labor room, where the rest of the protocols, as was mentioned, we'll be doing. And of course, we have to actually counsel her that she may require termination of pregnancy, but we need to consider that she's only 28 to 29 weeks. And therefore, she may require, steroid, etc. But actually, the aim will be that we have to terminate a pregnancy within a short period of time. We may get a couple of days or, depending on how her BP control is. Sometimes we may get even a week. But that depends to be seen as we are proceeding with her treatment. And also the condition of the baby, we would be monitoring. So on both these, we will make the decision to terminate. We cannot really do conservative management for many, but sometimes it may be possible for a few, days or maybe a week, something like that, which will give her a little bit of maturity for the baby. And these babies also, we have to remember, will have a certain amount of IUGR and certain Doppler changes also may be there, and that may actually necessitate us to terminate the pregnancy as well. She also has a high risk for abruption. So with all this, I think she may be at a better stand by, delivering the baby.
Latha?
Yes. If the fetal and maternal condition remains satisfactory, I would be wanting to prolong this pregnancy. How far? Every day will be a boon. I think every day I will be reviewing her for the indication of delivery. But I think as long as fetal and maternal conditions are satisfactory, or stable, I would continue with the pregnancy. I might not get very many days, very many weeks, but in occasional cases, it has been possible to prolong the pregnancy for a few weeks. Every week is very important for the baby. as we all know.
Yeah.
So I think I would try my best to prolong the pregnancy.
So I think this kind of a situation kind of reinforces that severe preeclampsia is a conflict of interest between the mom and the baby. And yes, the only reason we want to prolong the pregnancy is to see if this baby can get to a slightly higher gestational age. But as all of you have said, we are very worried about all the potential complications that this mother can have. And if we give, because very often this question is asked in forums that we've given the magnesium sulfate, the BP settles, is it okay to continue the pregnancy? Just because we've given the Maxsulf, we don't have to deliver, but we may not gain too much in terms of time. So hypertension is not the cause of preeclampsia. It is just the outcome of what is happening in the vasculature and the endothelial. It's an adaptive response. But when it becomes maladaptive and the blood pressure increases, then we are trying to control the blood pressure, mainly to reduce the risk of cerebrovascular accidents. They're not really correcting the problem, which is why everybody has been so guarded about saying that we are not sure how much time we will gain. We don't get lulled into feeling safe because we're able to achieve better blood pressures. So, moving on to this question of could we have avoided this? And I want to ask each one of you, the three obstetricians in the panel, as to how do you screen for preeclampsia in your practice? It's not what is advised as the best, but what are we actually doing? Rekha?
In my practice, we do the first trimester testing, and we do the risk factor scoring with the MFM criteria. And usually in that, either you do that or you can just ask for the risk factors. We have the high risk and the moderate risk factors based on that. Or if you can put it into the computer and you can get it online, the risks, then you can start them on EcoSprint from the 14 weeks or 15 weeks. So at 13 weeks, along with our first trimester scanning, we do the PAPE is included in the screening, and all the questionnaire is asked whether she has a first degree relative with hypertension, pregnancy-induced hypertension in her family, her obesity, everything is included in that history. And according to that, actually it just throws out risk association for you. And it also even gives you the fact that you should start EcoSprint. So it's quite a simple.
So are you using the formal FMF?
Yes, I'm using.
And artery Doppler, PAPE, PLGF model?
Not the PLGF alone, because that is expensive. The rest of it I'm including, except the PLGF, PAPE, and the rest of it, the formal one we are using, and the printout is taken, the Doppler is done, and it's attached to the patient's file, so that if they move on to somewhere else as well, they know why the patient is on EcoSprint.
Okay. What about you, Jyoti?
Yeah, since in my hospital, we do have a fetal medicine unit over there. So every patient, of course, taking the risk factors with the fetal medicine person, they're taking an MAP is taken with them, and then they do the 11 to 13 week scan. But yes, PGLF and all, actually, I start with the counseling of the patient. First, I tell the patient at the initial visit what is the importance of getting all these particular tests done. I know they're expensive. Many of them do not want to get it done. But I have realized, especially in the high-risk patients where I feel the age is more, they are on a higher BMI, or they've had a previous history of this, if we do counsel and they go to fetal medicine people, they do come out with that particular risk factor which there is there, and then we can start with the aspirin. But if they're not willing to get all these particular tests done, at least 11 to 13 week scan where you do get a uterine artery PI is available, where we have MAP is available and the risk factors are there. Considering all that, we do get an idea of the risk when it is fit. And based on that, I definitely do consider starting aspirin to them.
LATHA?
Yeah, I would agree with Dr. Jyoti. Okay, his history, MAP, UAD, PLGF, all these put together can give us a fair idea up to probably 75% of what the risk is. Yeah. So we might use aspirin more judiciously. That's what I feel. Yeah.
Fair enough.
150 milligrams of aspirin.
Fair enough. So I think the evidence for the use of multimodal screening is very strong. Yeah. There's no denying it. And it is actually the recommended screening method even by the FIGO guideline for screening. But the question, the points to ponder is, what are the implementation challenges? Now, when we are sitting in our individual practices with fetal medicine specialists, with the ability to do the uterine artery Doppler, we are able to give this risk prediction. But no screening is actually going to be impactful unless there is universal coverage. And when you take a country like India, implementing such a model, multimodal model, into the public health system has a huge challenge, and that is something that we need to think about. And whether, when we do that, can we actually take our eyes off the low risk group? So this is something that I think is worth a debate in itself, and some kind of consensus into what it is that we are going to do, because doing the screening in small pockets is not going to have the impact of a 70% reduction promised, because 70% of the population is not going to be screened in this fashion. I think that is something that is a challenge that we have to grapple with. Now, moving forward, you have delivered, let's say you took her through maybe at 30 weeks or 31 weeks, she's delivered, she's had a baby that needed to stay in the NICU for a period of time, and now she's fine and fit for discharge. What is your follow-up mechanism for such a woman? Latha, do you want to go first? What do you do in your practice?
Yeah, I mean, if she has had such a severe preeclampsia, we tend to give them anticonvulsants for at least magnesium sulfate for 24 hours.
No, she's delivered, Latha. She's delivered. She's going home.
Oh, she's going
When
home.
do you want her back? What will you do? I mean, you bring her back after 2 weeks to check her blood pressure, and then what?
If she is on antihypertensives, we follow her up in a week's time, and we would have told her about the imminent symptoms, and if she has to report immediately to the hospital if she has those imminent symptoms. But we do check her blood pressure in a week's time, and then see whether her medication can be tapered, altered, or tapered. So later on, we do a detailed counseling regarding the long-term problems associated with having preeclampsia. I mean, how she will be prone for hypertension, and 50% of women can become hypertensive in 5 to 10 years. That's what we would count.
So is there a mechanism to bring them back? I mean, are we following them up? Jyoti and Rekha, what happens in practice?
In my practice, like these patients with 180, 100, I'm sure they're sent home on the antihypertensive.
No, I'm saying you're seeing her at a 6-week review. She's gone off the antihypertensive at this point. So what I want to know is
delivery, isn't it, Uma?
Do we have a process in place for these women?
Yeah.
So actually that's a big challenge, till 6 weeks they do come back to us as a postnatal. We always see them at 6 weeks. So at this particular time, I do make it a point to counsel them about the long-term effects, give them lifestyle modifications, tell them it's important to lose weight, tell them about the particular diet, also refer them to a physician and ask them to get the blood pressure monitored themselves, that they have to do it at least twice a month, or maybe if possible, they can do it weekly. In case they find it to be high, to be connected to a physician and to be able to see them. And I would like to generally tell them to come back to me at least once in 6 months, so that I myself can check out that the things are fine and they are going on the right track.
Yes, Uma. I would like to add here that this particular woman that you mentioned is preterm labor, and she's delivering, she's obese, with a lot of risk factors. In addition, we have to think of thromboembolic prophylaxis when we discharge.
Fair enough.
So,
that's a very important point, and I agree that it is often missed in clinical practice. It is important that
so
it is
just like you asked, Uma, some systems have to be in place. If these systems are not in place, we forget. So 2 things which we have implemented is, after every delivery, we just have a column which without which they can't take a printout of the delivery notes, which says thromboembolic prophylaxis not required or required. One of that, if that column is filled, only the delivery printout comes. The second is, at every discharge summary, we write the one sentence saying no hypertensive disease during this pregnancy, so that the next consultant who sees in the future pregnancy at least will look at this and, and if it has been there, any sort of hypertensive disease that's mentioned. So this is very important for her future pregnancies as well, because many of them will just say, I had salt in this thing, they told me to reduce salt, something like that. So this is very important. And third, which we do is we see every patient at say 10 to 14 days as well as at 6 weeks. And at the 6-week visit, we do the GTTs if they are diabetic, we do the thyroid at that time, as well as if any hypertensive, then if they require any, kidney function test, that we do, and we advise them. But very often,
after that point, my question is after that 6 weeks. So we can handhold them till 6 weeks. The problem is the long-term impact of preeclampsia resulting in cardiovascular. So Sarah, I know you're not an obstetrician, but what happens in the UK? Is the system better geared to follow up these women?
Yeah, I think, well, whether we do have a system, whether that gets implemented is the question.
Yes. Yeah.
I would say, and it's bizarre for a diabetologist to say this, but I would say these women are probably even higher risk in the long term of cardiovascular disease than the milder GDM version of gestational diabetes. We tend to brand them all in the single category, so I think that is the key. If they are at the higher end of the spectrum of the gestational diabetes, yes, they do develop cardiovascular disease 10-20 years later. But a woman like you presented, I think, is much higher risk of cardiovascular disease. So while saving her life is important by delivering the baby early and all the attention goes to the little one and the safety, etc., it is natural that we forget about her long-term risk. Somehow we need to counsel her. Here we have explicit guidelines to the GPs.
And there is a hand-holding follow-up that happens.
That's right, and it says every 3-year follow-up, but we don't go beyond that, saying, look at her as a pre-cardiovascular disease patient, look at her glycemic status, look at her lipid status, not just the blood pressure. So I think if we highlight all of that, perhaps repeatedly convey the message, it may filter through to the mothers.
Yeah. Thank you. So Hema, any questions that you want to ask here?
So before I request David for the closing comments and his set of questions, there's a question from Tirunelveli. Okay. As of now, I'm happy to inform that 1111 is our score, 1,111 viewers for this brilliant program. So that's a real good number for working day afternoon. Uma, thank you so much. And the question to Latha is, since you mentioned about IV labetalol, Shanmuga Sundari from Tirunelveli asks you, Latha, how do you exactly use the IV labetalol? Dosage, when you repeat, what is it that you would guide your staff and your team to monitor, etc.?
Yeah. It's usually 20 milligrams diluted in 10 ml of saline that you inject slowly over probably 10 minutes or even a bit sooner. That's not a big issue. But I have found in my practice 40 milligrams as a bolus dose, which is more effective and brings down the blood pressure more effectively. And every unit should have a protocol how we use the IV levetolol because it's important that we have a syringe drive to put in the levetolol infusion and titrate it against the blood pressure. So it is used in boluses in the beginning and then as an infusion. Till the oral medication takes over.
Thank you, Latha. The question to Jyoti is, Jyoti said 180, 110, I'll put her on labetalol and, and I will send her home. Okay. The question from Shashikala from Salem is, tapering of antihypertensives postnatally, is it a challenge, and what is the kind of step down or withdrawal of the drug that you would consider? What is your thought process on that?
Okay, so if I get that right, it's about the postnatal.
Yes, tapering of the antihypertensives postnatally.
Okay, first of all, I would like to say that if the patient is on methyl-dopa, I'm going to be changing her on and not sending her on methyl-dopa. That's a message I want to give, because a lot of us had been using it, because after 2 days, we need to change over. So when I change over the drug, even if she's on labetalol or anything, I normally go on to the beta blockers. That is, I send them generally on the Amlong or the Ampress. Continue it till 6 weeks, monitor her BP. If her BP remains to be more than 140/90 despite the medication, I continue her to take this medication for longer periods of time. But if during the period of 6 weeks, I find the BP has come down to 110/80 or it is 120/80, then it's the only time that I ask her to taper it. And despite tapering, she has to be under continuous monitoring so that we really know that we can stop the medication at 6 weeks.
Yeah. Thank you, Jyoti. My very beloved Vice President of Foxy 2013, Maninder Ahuja from Faridabad. This question is to Rekha. Rekha, you also, mentioned that the DVT is a concern. So what is your protocol for early mobilization, and what exactly is the system of callback of these patients, even in a high-fi private setting? The patients do not follow up. Once they're out of sight, it's out of mind. 6 weeks, yes, maybe half of them will come, but later on, do you chase them? Is there a system in place for that? So 2 things. One is about mobilization, early mobilization post-delivery, and the second is about really making sure, as Sarah said, you have to have them back. What is your methodology of implementation?
Thank you very much, Maninder Ahuja, for that both the questions. The first question is, early mobilization is very, very important. So it's because many of them will be on epidural, so the epidural catheter has to be removed and the police catheter has to be removed, and she has to be encouraged for early mobilization. But my thing is, early mobilization alone will not do. In this particular patient, she is obese, BMI of 30. She has had preterm delivery, whether by cesarean or I do not know in this case what happened. Very often it could have been cesarean. And also the fact that she had preeclampsia, which means she is already into a high-risk category for thromboembolism. And therefore, just early mobilization will not be effective. So again, I go by the criteria. We have the thromboembolic guidance, in which if you're above 2, then you have to give thromboembolic prophylaxis by injectable means because so injections for 10 days or I know it's expensive and patients find it difficult to inject themselves. Of our patients, them in leave, they do. I hope they do continue. So that is one thing. So early mobilization for the very low risk group, it is fine. But if their category is high with the score of above 2, then it's for 10 days. If it's a score of about 3 or 4, then we have to continue for 40 days. So this is very important because we've had patients who come back later with press 1 week after the delivery. This was a lady who had intrapartum PI, discharged and came back almost 7 to 10 days late with a press. So for all these patients, unless we give thromboembolic prophylaxis, it could have problems. So early mobilization alone will not do. You have to risk categorize them. So that is question number 1. Question number 2 is, how do you get them for follow-up? One method which I use for a lot of the primees, especially with PIH, is that I make sure that every single patient has got vaccinations at particular times. And when they come back for vaccinations, which is I give them all patients, if they are not vaccinated, they get the, at delivery, they get 1 dose and then the subsequent doses. So they are forced to come back for the dosage. And therefore, when they do come back, we try to follow them up for whether it be thyroid or impaired glucose tolerance. And I also try to give them cervical cancer vaccine. So all these vaccines, when you explain, they feel that is the more, they will come for a vaccine, but they will not come for general checkup. with this vaccination, I do.
Thank you, Rekha. Both
So
points.
I think also, clubbing with the
both points well taken. Now, some questions and closing comments from our esteemed guest, David McIntyre. David, our minds, how much does the package of obesity, hypertension, and gestational diabetes mellitus? Oftentimes, they're all, packaged together in a single patient. So, how should our minds be looking at them as perceived risk for this category of people, amplifying the risks?
Well, you're right. They all come in together. I mean, I think one thing we haven't said is for late preeclampsia, effective detection and treatment of gestational diabetes is probably one thing that can prevent not this sort of very severe early case, but the later onset of preeclampsia is reduced by about 50% by effective detection and treatment of GDM. But we often do see women, and we, in Queensland, we have a protocol for women with marked obesity in pregnancy as well. And certainly I think the general therapeutic approach that everyone suggested is pretty much in line with what we would have done for this lady acutely. I mean, certainly we would try and prolong gestation for the time for the antenatal glucocorticoids, for the betamethasone to work. That would be our initial aim. And certainly we do see a number of women who look pretty bad when they first present with one very high blood pressure, but who may actually settle down better than you think. So I think that would be my short-term aim, but I would agree with people that in this case, as you described, you'd be lucky to get more than a week or a little bit over a week in prolonged gestation. But you'd certainly, we do exactly what you said, look at mother and baby. The only other point I would make is that we do, with this severe early preeclampsia, we look carefully for procoagulant states, including lupus anticoagulant, antiphospholipid syndrome, other inherited procoagulant defects. So we would do that as a routine in anyone who presents with early severe preeclampsia. And then in our clinic, we would follow them up till we're happy that the acute changes of preeclampsia have resolved. But then, probably as in the UK, the follow-up will be with their general practitioner. And that may be a difficult transition because the general practitioner, both in GDM and in preeclampsia, may feel that the acute problem is pregnancy-related only, and then that it's sort of basically gone away. And our other tactic is to try and get them opportunistically with the baby's vaccination. So most of our cervical cancer HPV vaccines are done in teenage girls these days. So that's not, there's not too many regular adult vaccination protocols. So we probably try and see if we can line up with the baby's vaccinations.
Yes, because Anil Kapoor and Mojay and all of us have been talking about linking the vaccination program to long-term follow-up of the mother. One last thing, David, I would want a comment from you. In the PNCD group, we often discuss about the ideal or the desired, recommendations, and then step down the lower middle income countries. Similarly, the ground realities for hypertensive disorders, when the FIGO has defined that risk stratification, as Rekha said, with the FMF Foundation, the software which is there, the BP measurement, the MAP, the Doppler, and the biomarkers, about which we had much debate. Of course, I have voiced out many times that the ground realities here, in the software of the risk stratification, there's so many unknown answers. And unless you really key in what the entire, document, it doesn't move forward. So it is difficult, easily said, but not only the time, but also just the fact that the risk factors are oftentimes unknown. That is one. And the second factor is the different BP size cuffs and the capacity even to take blood pressure in the manner that it is required. In the checklist, we often say, make sure the BP apparatus which is working is there, and leave alone the competence for the Doppler and the biomarkers, which access and availability, affordability, all three are in question. So when you work your mind on stepping down for the LMIC, where do you think we can strike a compromise, and where do we move from here for
Yes, so look,
Yeah.
I don't tend to actually do this because I only tend to see people who get into trouble rather than the women who are, being risk stratified early in pregnancy. But my understanding from Leona Poon is that the clinical assessment, particularly with standardized blood pressure measurements, proper cuff, calculation of mean arterial pressure, can get you, somewhere between 70 and 80% of the predictive value. So I think that's something that just about any clinic can probably afford to do well and standardize. And then if you have local availability of ultrasound, you can do uterine artery Doppler. That probably gets you another 10% along the way. And then, sure, in a lot of places, the biochemical measurements are the most expensive part. But I think you can actually get a long way towards the prediction and prevention of early preeclampsia with the simpler side of the measures. And so you don't need to feel bad about not doing everything if you do at least some of the measures and you do them in a well-organized, systematic way.
Right. Thanks, David. We are also exploring, and I want Suchitra to speak about Gestosis score, because there have been several debates in the country, and unless we disagree at the start, finally hit upon a compromised formula, again with the intent of doing the best that we can and move ahead with picking up more number of cases and doing better on them. So Suchitra, the Gestosis score is what I wanted you to outline.
Yeah. Thank you so much, Hema, for giving me this chance to speak right now at the end. It's the Gestosis score was actually devised by the organization Gestosis Group. And the whole idea is, I know we are talking about actual evidence-based practices, but here is this particular simple score which can be done at all the LMICs. And basically at the first visit, it's when you're taking a detailed history, at that time you start picking out certain points, and we've made like a simple printout chart where you're ticking off the points, and we give a score of 1, 2, or 3. So anybody who is between the ages of, if less than 20 or more than 40, or if the BMI is between 26 to 30, or she's had a history of a hypertension in the previous pregnancy, or if this woman has had an interpregnancy interval of 5 years, and if she's got a maternal hypothyroidism, and she's got some such story of an abnormal glucose, all those merit a 0.1, a grade 1. The next one is if she's actually got gestational diabetes and if she's got hypertension in the immediate previous pregnancy, she merits a score of 2. And of course, along with this is the BMI if it's above 30. And the group which merits 3 is if they've had a severe episode of preeclampsia and postpartum complications, if they've had a history of thrombophilia, it could be acquired or inherited, history of a CKD or history of a previous hypertension, which they probably were not aware of, but that somewhere they remembered and they told you about it. And if the woman has had an ART pregnancy, now mind you, in ART, assisted reproductive techniques, we are not talking about IUI, but we are talking about IVF in the higher order and the multiple pregnancies, all merit a score of 3. So if the first visit you've done this tick mark and you get a score of 3 or more, this woman is at a high risk for developing preeclampsia. And we start off, what we are recommending is starting off aspirin at this stage itself and giving her also 1 to 1.5 grams of calcium, because calcium is what is important, particularly in the lower calcium consuming population, which could be the LMICs. And, you're also talking to them about coming for a very regular follow-up. And of course, compounded with this, if it is possible, we go ahead and, when you're doing the scans and you're doing the first trimester scan and then doing the dual markers and the Doppler studies, of course, then those are the things which the panelists have already spoken about. But the Gestosis score is simple, easy, doesn't cost you anything apart from that additional 5 minutes. And you're still screening for so many NCDs at one particular time. So
Thank you so much, Suchitra.
Medical colleges. So, Hema, hopefully we'll be able to validate that score very soon.
Yeah, thank you so much, Suchitra. We will, before Uma moves on, we'll take one closing comment from Dr. Saravanan. Sarah?
Thank you. Thank you, Hema. I think all the points are highlighted, but I just wanted to add just two very simple common sense approach too. And like what Dr. Suchitra said, I would add family history of hypertension, which I know it can be tricky to elicit, but I think we should always remember that. The second is ask the mother's birth weight, if she can remember. Most of us in India will remember or vaguely remember their birth weight if they are small at birth, and I think they are particularly at higher risk. And the third point I would say is simple, regular blood pressure measurement. And think of the relative change or relative deterioration in the blood pressure. I would myself keep maybe a 15% increase from the booking time as an alert and say, is this woman heading in the right direction? We have very little data on gestational weight gain, but I think even in low socioeconomic group in India, the BMI is increasing, and therefore I think that gestational weight gain plays a crucial role. So these simple things, if we can focus on, I think we will be able to pick up these women much, much earlier.
This is a real value add, Sarah, because this really hits on the implementation point, what is doable and what we need to focus our attentions on. And thank you so much for this input. And David and myself will ponder with the group about this, with Sheshaya's brains also working double time, producing paper every 15 days. And we are thinking about a lot of things in this COVID time, which has helped us reflect. So we will soon see that even in our Manyata and quality training programs, will empower the staff nurses to do this quick check so that it is a way of making it visible. So thank you so very much for the same. And Uma, yours now, the next case. Thank you.
Okay, thank you very much. I think there is very useful discussions around implementation. And we move on to the next scenario. This is a 28-year-old who has had her first full-term normal delivery, 3.8 kilo baby. At that time, she had gestational diabetes and was managed on diet. Now, her booking BMI is 32. Now, she books for antenatal care. And, Sarah just kind of preempted the question by talking about optimal weight gain in pregnancy. So can I ask Jyoti, what would be her optimal weight gain in pregnancy, and then bring Shilpa in to tell us how we should actually be advising her about diet and activity?
So since she's already on a BMI 32, so her optimal weight gain, according to me, would be somewhere between 7 to 10 or maximum 11 kg during the pregnancy, since she's on a higher BMI for that.
Okay. I tend to be a little stricter, but let's hear Shilpa's point of view. You have to unmute, Shilpa.
For the diet or the weight gain?
Both.
Okay, so I think weight gain is something that the gynecologist would be more right person to recommend, but I would also think that 10 kgs is a little more, maybe 7 to 9 kgs would be somewhere around what I look. Well, she will need a lot of advice with her diet because she's initially coming with a very high BMI, and therefore definitely there is something in her diet, or either she's too relaxed about her diet. So we need to talk to her about her diet a lot. Especially, this is an Indian woman, right? Yes. So we need to talk to her about her carbohydrate intake. But that's a huge, huge challenge in India. So that also, if she has GDM again, then that is going to be a huge problem. So getting her carbohydrates below 50% of her total calorie intake, which are of low glycemic index, increasing her protein, that's again a huge challenge in India. Women do not consume protein at all. I mean, even higher socioeconomic strata women do not consume protein. So I think that is something that we will need to talk about. Reducing her visible fat intake in terms of fried and processed food, but increasing her invisible fat intake in form of nuts and oil seeds to maintain a requirement for essential fatty acid, and of course encouraging a lot of micronutrient rich vegetables and fruits in her diet. I think, and physical activity, some amount of physical activity. Now that depends. She's already pregnant, and if she has never exercised in her life, we are definitely not going to ask her to do something big, but maybe begin with a walk or something, whatever she can manage to. There is also a lot of yoga, etc., which is available for pregnant women. So whatever she can do, that is something which is important that she should be doing.
Thanks, Shilpa. Sarah, I have a question for you. We have the only guidance we have for optimal weight gain in pregnancy comes from the Institute of Medicine guidelines. And, given that our South Asian BMI cutoffs are actually much lower than what is given for the Caucasian world, we actually then have no guidance about what should be the recommended guideline for our women, isn't it? I mean, can we just translate that, because that's what we are doing now for want of anything better? What would be your take on that?
Yeah, it's a very good question, Uma. As you say, we don't have any Indian specific evidence base for this. However, I think we all agree if we want to use BMI as a starting point, we could use the Indian specific BMI cut points for overweight, obesity, and so on. We can apply the Institute of Medicine guidelines. I think personally, this is my personal view and my anecdotal view of looking after the South Asian women in the Midlands area in the UK. We can be a lot stricter. Yeah. Especially this woman who's already had a GDM. I presume there is a 1 to 2 year gap between the first pregnancy. So she already delivered a big baby for Indian standard, and her booking BMI is 32, which would be in Caucasian standard, you're talking about probably 37. So in that sense, we do have evidence. There's a study in Denmark, you may have seen Peter Dam's group who did the work about 10 years ago, where they actually, with a BMI of 35 and above, so if you translate our Indian context of BMI in this lady, she will go beyond that. They restricted less than 5 kilos weight gain for the entire pregnancy. And much our concerns about smallness of the fetus and fetal undergrowth, etc., was not there in that studies. And they subsequently did a much bigger study, which again confirmed the same. So I think this lady, we could probably be a lot more aggressive. Yeah. And again, I would use, in the absence of evidence specifically in the Indian population, just ask her the simple story of how much she used to weigh before her first pregnancy, how much she used to weigh when she was 22 years old, 23 years old. And that's probably her weight. As long as she doesn't go beyond that, I think you will be pretty safe, I think. And just a small comment on what Shilpa has just said. I think she hit the nail in terms of the diet aspect. So I would add, in addition to what she said, is avoid snacks. I know snacks are hugely important for us in India, and I think we underestimate the calorie in the snack. And it is common that the mother say, oh, I only have a small portion of meal, I don't eat rice and so on. But what do they eat in between is the key.
Yeah, I think it's very true. We do tend to restrict weight gain. In fact, it's interesting because in many clinics, the woman who doesn't have gestational diabetes doesn't get the benefit of dietary advice. So at least when we track our women, we find the women with GDM actually have restricted weight gain, but the women without GDM end up gaining a lot of weight. And given that we have such a high prevalence by the time they hit 28 weeks, their sugars may just go higher because they're gaining a lot of weight. So I think she has enough risk factors to warrant a specific diet counseling, which a busy obstetrician in a 15-20 minute consult is unlikely to achieve. So it's important that that counseling happens. And I've just put down the FIGO nutrition checklist. It's very simple. It gives a checklist for the woman to fill. It gives additional details for the healthcare provider, what needs to be done, gives the data on what should be the weight gain, and also suggests, what are the things that should be done pre-pregnancy and post-pregnancy. It's a useful sheet to actually download and have. And if you don't have a dietitian in the practice, then you could use this to help, achieve the information that you want to give. So, so this woman has all the risk factors, and all of us know that we are, she's probably going to develop gestational diabetes this time around. So, Sarah, how good are we with predicting? I mean, in this case, yes, I mean, the chances are very high, but how good are we at predicting JDM? We had a discussion about screening and what to do to detect, but...
yeah, I think we, so far, our efforts has been creating a simple diagnostic tool for gestational diabetes, which I think is important, but I genuinely believe that we miss a big trick because of that. Ultimately, it's the prevention is important, because by the time the women develop GDM, whether it's 16 weeks, 24 weeks, or 28 weeks, if our concern is the long-term health of the offspring, we've already lost the boat. So I think we need to think about how can we actually prevent it. For effective prevention, we need effective predictive models. Hence, our study will hopefully provide some answer to that. There has been some attempts trying to do that with the risk factor-based screening, and unfortunately they are not that effective, because I'm more worried about a thin woman with a family history of diabetes end up having gestational diabetes than obese women without any family history. So it is the overall risk that matters. So combining the family history as well as some of the simple measurements like height, weight, as well as potentially mid-arm circumference and waist circumference and so on, along with some simple biomarkers. We are testing HbA1c in early pregnancy in our Indian study, which, as you know, the preliminary data is looking quite good. I think we can predict them. Of course, like any predictive test, this is not going to be 100% sensitive and specific, but I think if we combine the other risk factors along with some simple biomarkers, we need to have something simple that we can implement in India and other low middle income countries, and hopefully we can do that. There has been some evidence to support a certain genetic markers can also boost this. But again, this is expensive, but if it becomes more effective, hopefully that will also come into play in the near future. But I think we can effectively predict. For this woman, yes, as you say, it is quite straightforward. It will be a surprise if she doesn't have GDM.
Yeah.
But I think if she didn't have, if this was her first pregnancy, given her BMI, I would say she is, again, very high risk, and therefore we can already start implementing some of the dietary guidelines, etc. But yeah, we can effectively do that if we measure HbA1c, for example, in early pregnancy.
Okay. So Shilpa, Shilpa mentioned the role of micronutrients, and so is there any evidence about their use in prevention of adverse pregnancy outcome? Or
So folic acid is something which is known, folate, for prevention of neural tube defects. But there is a lot of evidence also coming for supplementation of vitamin B12 for prevention of metabolic disease in the child later on. And that these are two things which are, I think, and also maybe protein. We do not have much evidence, but I'm just saying it on the lines of that we know that at birth, Indian babies are more sarcopenic. They have high fat mass as compared to the Western counterpart. And hence, I think inclusion of protein-rich, micronutrient-rich diet is very important. What is seen is most of the Indian women tend to eat, but they tend to eat very, very refined kind of food, which is essentially like Dr. Sara said, that it's essentially snack which are high fat, high sugar, high salt kind of things.
Yeah. Okay. So we'll move on in the interest of time. She initially, her glucose screening was within normal limits. At 24 weeks, she was diagnosed at GDM. Now at 28 weeks, her fasting sugars are in this range. I mean, this is all milligrams per deciliter, 96 to 100, and 1 hour is about 150 to 158. So there have been some questions in the group and from the audience as well about the role of metformin, and would that be our agent of choice, or should we be giving insulin? So a quick take. Let me ask the obstetricians first what they would prefer to do, and then I'll come back to both Sara and Professor McIntyre. Rekha, if just quick answers, please. If you had sugars like this and she's been on a diet, what would be your choice to improve her glycemic control? I can't. You have to unmute yourself. JYOTI, while
metformin. Uma?
Metformin. Okay. JYOTI?
Yes, I too would prefer to first go on to metformin, and if it's not controlled on metformin, then think about
insulin. LATHA?
Metformin.
Okay. All right.
So, just want to make sure that she is on proper exercise also.
Uma? Yeah. How was she diagnosed at 24 weeks at GDM? Did you do a test at 24? Usually we do it at 26, 28.
Yeah. 24 weeks she was diagnosed.
Some other.
Yeah. No, I mean, she had her screening again at 24 weeks. We tend to do at 24 to 26. So, okay. So there's no debate among the obstetricians, but there is usually a debate when we have endocrinologists or diabetologists on board in our forums.
Yeah.
I know Sara will also agree possibly, but do you want?
Yeah, I don't need to convince this panel, so I'm pleased. So I think, yes, we do need, if I put my research hat on, do I fully understand the 5-year, 10-year risk to the offspring with metformin? Mm-hmm. Yes, I don't have the answer, but I think there are important points to remember. We have very good evidence that even in before 12 weeks of pregnancy, use of metformin do not increase congenital malformation. So I think that is the one thing that we worry about. So I think we can safely say we understand that from data from obese mothers, from PCOS mothers, and so on. The second thing is we do know it is effective, not just, there is a misconception sometimes that this is only effective for fasting hyperglycemia, but it is not. It is very effective for postprandial control too.
Yeah.
And then the third thing to remember is it roughly halves the risk of preeclampsia. So if you use metformin, the mothers gain less weight and they are also less risk of developing preeclampsia. So in terms of the pregnancy outcomes, it is very favorable. Do we fully understand what happens to the little ones? I don't think we have enough evidence in terms of are we actually do more harm to the offspring. I think the early evidence shows we probably not. And does it actually reduce the risk of childhood obesity? I don't think that evidence is there. I don't think we can use it for that purpose. But when it comes to pregnancy, I think it is a pretty solid evidence.
Okay. So in terms of monitoring her, Jyoti, or LATHA, any other parameters that you are monitoring or alongside her sugars? Are you just happy that when her sugars?
With her, because she's a diabetic, she's a BMI which is very high. The things I would like to monitor is her blood pressure, because she's very prone to develop a preeclampsia or a gestational hypertension. Weight gain, of course, how much she's gaining, because that's a parameter which tells her whether sugars are going to be well controlled. And even the baby also, the fetal monitoring is very important, because as far as the growth of the baby, if the weight is concerned, the amount of LICA that is growing, if she's developing polyhydramnios despite a normal one, then we know somewhere that things are not going all right. So all these factors also simultaneously to be monitored.
Yes, I think that's a very important message, because sometimes we, especially if sugars are not being monitored with the kind of intensity that is recommended, very often sugars are just checked once in 2 weeks or once in 3 weeks, and they are apparently normal, but then you see this baby's growth chart and the abdominal circumference is growing up, there's more polyhydramnios, then clearly that's an indication that something is not quite right about her glycemic control. So when would you like to, let's assume her sugars come under decent control, LATHA, and when would you normally time her delivery?
Yeah, she is on metformin now, and if there is no macrosomia, if the movements are okay, if there are no other concerns like preeclampsia, etc., I think I would time the delivery around 39 weeks. I would push it to 39 weeks. Even sometimes 39 plus. So I don't think we should be delivering them earlier than that, because of the problems of early terms also. So around 39 weeks.
But we are a lot of us are very worried about the potential risk of stillbirth. And I think in general, let me take a quick gestational age response from Rekha. What is the gestational age at which you deliver somebody who's on metformin?
Metformin, if she's well-controlled diabetic, I would go, as Dr. LATHA said, 39, even 39 plus. Okay. But I would, scan her around 38 weeks.
Fair enough. Yeah. On insulin?
On insulin, if there is macrosomia, then I would go in at 38 plus to 39 weeks. Because, usually these are macrosomic babies if they are not well controlled. And even in these babies, sometimes if they are macrosomic, then I would prepone it to 38 plus rather than, 39 plus.
Okay. So, because there is a tendency for many people to deliver women who are diabetic in pregnancy and who need medication early, 37 weeks or even before 38 weeks. And there is a little bit of concern about these babies that are born slightly early. This woman developed hypertension at 36 weeks and she was induced at 37 plus and she delivered normally. What are our concerns for her postnatally? I think everybody in the panel did discuss, even in the last case, that they would bring her back around 6 weeks and get her GTT done. But what percentage of our women are we able to actually achieve this even in our practices, it doesn't reach 100%, the women who come back and have their GTT. Now, I just want to pose this question. Let's say you have another woman, she's 28, she has a BMI of 24, she's diagnosed to have gestational diabetes at 26 weeks. But other than the abnormal value at the time of screening, all her sugars have been normal. She's managed with diet and exercise. Now you have both these women. Are we going to look at them in the same fashion in the postnatal period? Or would you just push the first one to have her GTT, and if the second one doesn't have it, are we happy?
No, I think I would be more careful with the second one. Okay. So a thin woman developing GDM at 26 weeks. Again, I think we have to be careful about her glycemic status postnatally also. 6 weeks GTT is important, and also annual monitoring of fasting blood sugar and HbA1c probably. And I would advise her regarding lifestyle changes because family history is also very important here. I don't know whether this lady has a family history of diabetes.
Okay. So I just wanted to get a perspective about mental health and wellness, and maybe Sarah, you want to comment on this about stress and the significant amount of mental health impact that is there, which we actually underplay. We don't really focus any attention on the diagnosis of gestational diabetes or hypertension and what it does to the woman. And NCD and this whole concept does include mental health and wellness in it. So that's the reason I thought I'll ask this question.
Yeah, I cannot emphasize enough, Uma, because I think there is still a huge stigma, especially in ethnic minority women, even living in the UK. So they don't share, so they hide. We also have very little objective way of measuring the contribution of stress to these women, the stress and anxiety. We all would have had many patients, I'm sure you would have had several in your practice, how a woman, especially some of them working and juggling many things at home and work, and they stop working and their blood pressure, their blood sugar levels improves dramatically. So we do underestimate this as healthcare professionals, and the patients underestimate it. So I think we had a very good data suggesting that even early pregnancy anxiety levels is an independent marker of women developing gestational diabetes. We've not yet published on that, but there is a close link. A woman who have depression antenatally, as you know, have higher risk of postnatal depression. And that also not just impact on their mental health and well-being, but it has a big impact on their physical health. So hence it makes it even more important to pick these women antenatally if you can, and somehow support them through the early postnatal phase.
Yeah. So we are well aware of the long-term risks of women with gestational diabetes and a higher cardiovascular risk. And we are also aware that there is a gap between what we want to achieve and what actually happens. So maybe we can have a couple of comments from Sarah and Professor McIntyre about what we can do effectively in systems to reduce this gap. And then Hema, you can take on with the audience interaction.
Yeah.
Professor.
Yes, well, I might address this one. I guess that, we all know this, but in our healthcare system, I don't think much is actually done about it. I think that early postnatal glucose tolerance test is useful because that helps identify the highest risk women, as does the fact that the woman with the more severe glucose tolerance test abnormality and the woman who's required medication instead of just diet. So they're all factors we can assess that identifies the highest risk. I think it used to be said that it was 50% diabetes, but I don't think if the HARPO study can be taken worldwide, it's actually 50% impaired metabolism, of which about 10% is impaired, 10% is actual diabetes, and the other 40% or so is impaired glucose tolerance or impaired fasting glucose. But it's still very significant. The other thing we've found in our studies in this area is that the women switch their focus, and everyone else does, totally to the baby and the baby's health. It's very difficult to get them to pay attention to their own health. So I think the approach needs to be one for the whole family rather than just for the women. as we said before, these women can be stigmatized, being sold that not only are you, overweight, but you're diabetic as well, and you're damaging my child or my family's child or whatever. So I think that we have to really fight against that and give these women a maximum amount of support. And I think blaming them in this situation is very negative and very counterproductive. So I think we have to develop, positive strategies. The other thing we should probably mention here again is metformin. So if all of that fails, as it may well, and you have a woman who's struggling with her lifestyle changes postnatally, there is very good evidence that metformin in this circumstance works well in the prevention of diabetes. In fact, better in women who've had previous GDM than in the standard diabetes prevention trial. So I think that's another useful therapeutic approach to take. And I think there's some increasing evidence in other populations for the Mediterranean style diet as being another, dietary preference that has probably, good preventative value. So they're the sort of things we try, but I have to say that when we've done studies in this area, we have to approach around 10 women before we get one woman who's thinking that she might sign up to a randomized controlled trial to do with her own health and her own lifestyle postnatally. So it's definitely not something that's in the forefront of their mind at that point.
Just if I can add to that, David, if I may ask a quick question, have you been able to persuade the healthcare professional to look at the women's lipids in Australia as a cardiovascular screening strategy rather than just a glycemic screening?
I think the whole thing falls down postnatally on every level. I mean, the blood pressure screening, the glycemic screening, and the lipid screening, because we know from the studies of Ravi Ratnakaran in Canada that even the women who don't progress to diabetes, if they have previous GDM, they still have a higher cardiovascular risk. So I think it is absolutely important. I don't think it's well done at all in Australia. I don't think we've had success. We don't even have success in our young patients with known diabetes. Our young type 2s obviously have a very high lipid risk. And it's difficult to get people, to consider the idea of medicating them, even with quite bad lipid profiles at a young age.
Certainly in the UK, I'm pleased to say after about 5 years of push, we have an agreement to enroll these women. So in the UK, we have the Nationwide Diabetes Prevention Program, and when it got rolled out 4 years or so ago, these GDM women were not highlighted. So with the much push and persuasion, they've agreed that women with the previous history of GDM should give priority to enter these prevention program. I think the bullet point that Uma highlighted is from the UK, from our UK study, which shows that only at 30% of women have their blood pressure and lipids measured by 3 years after their index pregnancy. So there's been a push within UK to highlight the cardiovascular risk. We've just completed a study again. Hopefully the paper will get published in the next few weeks, which shows if you actually create a tailor-made education program for women postnatally, then they may be encouraged to think about this as a risk modification post pregnancy. But I agree, we had difficulty in getting women to partake in the study. We had a little bit more success in our center, where about 25% of the women said yes, as opposed to other centers. But again, that's because we were working through them from antenatally. So I think this message has to be passed through from pregnancy, and that's where I think you guys come in as obstetricians, because women follow whatever you guys advise. If you make them walk on fire, they probably walk on fire. So you need to keep them going through the pregnancy and get to them early postnatally through the vaccination programs, pass on the same message. and then hopefully that will stay with them in the longer term.
Yeah, thank you, Sarah.
Sorry, I agree with David. If lifestyle interventions is failed, we do have metformin, which has a decent evidence that women with the previous GDM actually do better for diabetes prevention when you use metformin on them.
Thank you, Sarah. Countdown for closing actually is beginning because we are left with about 15 minutes of program time, and we know that both our distinguished guests, David and Sarah, from different time zones, and it must be late in the day for them. The question that was posed to both of you by Uma is, how do you make sure that these women will come back to long-term care? And you very well outlined the challenges even in affluent countries where the affordability and awareness is already there. NHSF data in India, we want 100% of our pregnant women to be tested. Antenatal testing itself is only 15.8% of these women are covered. So we have a long way to go, both antenatal and postnatal. So one thing at a time and one step at a time. And we will move forward on that. And another piece of information for all our audiences, the FIGO Pony group is working very closely with UNICEF, with our organization Artist, and also the Ministry of Women and Child Health and Nutrition and Dietetic Advisors to put forth the weight gain parameters and the North, South, East, West Indian diet for the groups that are concerned, both pregnancy, antenatal, and postnatal. So there's going to be future discussions and webinars on these topics as well. So just watch this space for the future. I just want to raise only one question from the audience, that is about metformin. Doctor from Salem says patients are very apprehensive, but despite that, very non-compliant as well. So they are worried, but they will not do what they are expected to do. That is the true scenario. Can we use metformin throughout her pregnancy? The question that I'm posing, I want to again clarify to the audience, many of whom may not know what is in the recent guidelines in Government of India and as well as FIGO. We have always had great debates with our diabetology counterparts because in principle, yes, the metformin has got into the recommendation for use pregnancy and early part of the pregnancy till 12 weeks. There again, the next phase of metformin use is only after 20 weeks because there's no data for use of metformin in pregnancy between 12 and 20 weeks. That's what is the argument about. And therefore, the question on can you use it throughout is, not as per the recommendations. And the second point is, the ADA has kept on hammering about the long-term impacts of use of metformin. All the diabetologists across the table in our ministry meetings say, really, you obstetricians want to campaign for metformin, but we don't agree with you. David, how do we counter them? Is this long-term risk of these babies really worrisome that we lose out on the short-term control of their glycemic status? What should we do?
I think I'll repeat the same, Hema. I think if the concern is the congenital abnormalities, I think we can tick the box in the sense we don't. So I think that it is safe. The second question is, do we actually continue metformin throughout the pregnancy? I would, because it's always, again, a risk-benefit balance. We don't have evidence, but the other reason I use is it helps with the gestational weight gain. If you're introducing someone insulin at 16, 18, 20, 24 weeks of pregnancy, it does increases the weight gain. What does it do to triglycerides, which we didn't really discuss because we don't know how to monitor and how to treat triglyceride levels in pregnancy. Triglyceride is one of the biggest factor for fetal weight gain. So, and we do not have effective strategy apart from weight restriction. Metformin might indirectly help that. That's one of the reasons I persuade my mothers to continue metformin. And then in terms of the third question is long-term risk. Yes, we do need more evidence. but we are talking about 10, 20 years of evidence. So how long do we need the studies? Do we need to follow the babies 5 years, 10 years, 20 years? Then you have the risk of not able to follow up the entire cohort. Then the study becomes, the findings becomes difficult to interpret, including the MIG trial in Australia and New Zealand, and David knows this much better than I would do, and despite their best efforts, they would not be able to follow up the babies. So in terms of the long-term risk, I think, and the benefits of the short-term risk, I would use metformin anytime.
Could I make a couple of
David.
comments? Could I make a couple of comments here? So we have looked at the triglyceride levels in the MIG study, and we found that, in fact, the triglyceride levels went up a bit more in the metformin-treated group between, say, 28 and 36 weeks than in the non-metformin group. So more or less the opposite of what you might expect. So I don't think there's any likely benefit there. But on the other hand, we've recently had the publication of the MIGHTY study, which we're involved with, which is metformin in type 2 diabetes. And in that study, metformin was started very early in pregnancy, or anywhere, up to about 20 weeks or so, but a lot of early pregnancy starting of metformin, and there were no complications. So I think that idea of congenital anomalies, etc., is not the problem. There is this long-term question mark, and it's a matter of, are the babies becoming a little bit fatter by age 2, and are they getting bigger overall and possibly a little bit fatter by age 6? So that is probably the opposite of what we'd like to see, but a lot of that data comes from polycystic ovary syndrome, where we have to remember that the women aren't actually diabetic who are being treated. So whether the same thing holds where the mother is also hyperglycemic and you've got a metformin effect and a hyperglycemia effect is not all that clear at this point. But I think, as we've said, before Sarah said, the immediate pregnancy outcomes are equivalent to somewhat better with metformin. I think no one here has discussed glibenclamide or glyburide, which of course was the treatment of choice in the States until quite recently. And I think people are now starting to see the negative effects of that. The only other comment I would make that I didn't make before is that if you're going to use metformin, you can't use it and then use a relaxed set of glycemic goals. You've got to appropriately titrate it. You've got to remember that at least 50% of women are likely to need insulin as well. So it's not an excuse for doing a half-baked sort of treatment of the glycemic levels. And, I think that's very important, that you don't sort of start one tablet and then come back in a month and think about starting the second tablet, and then, you're a couple of months in by the time you realise you need to start insulin. You need to keep those women under close observation and titrate quite rapidly.
Thank you so much, both of you, because the next time on, when we have this argument on the table at the ministry, I think we will say about the risk benefits, and not to wait on and on and on for the next 12 years or 15 years to see what we should be doing with our women, the best we can do this point in time. There are more and more who have now entered the webinar, nearly 2,000 plus, and Ishwar Malade and Manindra Ahuja, Rahel Sikandar, and many others are saying this is awesome and it's a very, very good webinar, and they're getting a lot of value for their time. So the distinguished faculty today, which has been showcased by Uma and myself, we owe much thanks to you. The last of the cases on term waiver. We may have to close this, so I would urge all the panelists to give a rapid fire round of answers for the questions that Uma may pose, and we will be certainly letting David and Sarah go in the next 10 minutes. Thank you.
Yeah. Okay. No, so this is just to bring focus on another aspect which increasingly we don't, I think of as an adverse pregnancy outcome, simply because our NICUs are getting better and better at handling these babies. That when a woman delivers, let's say at 33 weeks or 34 weeks, we are not so terribly worried, at least when we are in the metros and in, having a good kind of a NICU. So I just thought, in the interest of time now, we'll just look at 2 or 3 issues. The first is, what are her, if you see somebody who's had a previous preterm birth, Jyoti, do you quickly want to tell me what are her chances of having another preterm birth, and do we know how we can reduce this risk?
So this is one of the most single important factor for a repeat preterm birth, that is a history of previous preterm birth or a mid-trimester abortion. So if you look at this one factor itself, we say that nearly 30% chance that she has of having a preterm birth again in this pregnancy. So question is, how can we reduce this particular risk? Now, in this particular patient, as we of course need to take a detailed history, look at the other medical factors which could have led to that particular preterm delivery. And if we do find something which we can change, we can start modifying that. But otherwise, to be able to reduce the risk in this pregnancy, we need to basically screen her for her chances of preterm delivery in this time. And that would include doing between 16 to 24 weeks. We need to have a look at the cervical length and see and monitor the cervical length thereafter and to see exactly whether it's shortening. Because if it is less than 25 millimeters, then the chance of her having a preterm delivery tends to increase. The second aspect that I am quite in favor, which is used in US also, is that if a patient has had a risk of preterm, then I prefer from 16 to 20 weeks to start her onto 17-hydroxycaproate to be given weekly, 250 milligrams to be done. I would also like to screen her for asymptomatic dysuria because that's one of the chances which can lead on, and also to look for bacterial vaginosis and correct these factors to be able to reduce her risk.
So, Latha, I have a question. Jyoti spoke about screening for cervical length. Now, this is a woman who's had a previous preterm birth at 32 weeks. Would you, if her cervical length was, let's say, 3 when you screen her at 18 weeks, are you happy to watch her? Or would you initiate progesterone in that instance?
No, I'm happy to watch her.
Okay.
Yeah. I don't know the details of how she went into labor.
So let's assume it was a spontaneous preterm labor. She didn't rupture membrane. She went in cramping, contractions. There's no dilemma about what actually happened.
She labored for a good duration, etc. I would be happy to watch her, Uma. I wouldn't go in for any circlat or anything like that. That itself might cause more problems.
Fair enough. But would you give her progesterone?
No, not really.
Not really. Okay. Rekha, you have somebody who's had one previous preterm. What if she had had that preterm birth at 28 weeks? Would you have then given her progesterone, or irrespective, you would
I would
get her cervical length?
Progesterone? So if she's had a preterm birth at 32 weeks, she could very well this time have a preterm birth at 28 weeks. So I would like to watch her cervical length from 16 week onwards. And also,
will you initiate progesterone?
Yes, I will initiate progesterone.
And what progesterone do you use?
She can have a
vaginal progesterone.
Natural progesterone vaginally at night, 200 micrograms.
Okay. So I think there's evidence for both, and the evidence for natural progesterone is quite strong. And sometimes women tend to prefer that to having a weekly injection. But I think, so the dilemma I wanted to bring out here is, would we initiate irrespective of her cervical length, or would we do cervical length screening in somebody who has a history? I think if you are going to wait to see if the cervical length shortens, then you need to see her at least every 2 weeks, and then take a call if you start seeing shortening. And it's important that obviously the length is measured appropriately. If you're not in a facility where you can offer that repeatedly to a woman, I think there is enough evidence to make a case for initiating progesterone to reduce her risk of preterm labor going forward. Now, would you electively steroid her? Just a yes or no. Right now she's on progesterone. There is no no indication of threatened preterm labor. She's just had one preterm birth at 32 weeks. You're seeing her at 30 weeks. Will you steroid her? Just a yes or no from each of you. Jyoti shaking her head to say no. Latha saying no. Rekha saying no. Okay, so a very strong message here, because there is a lot of abuse of steroids, antenatal steroids. Effective as that intervention is, I think we need to be cautious about using it, because there is data about the long-term impact of antenatal steroids on the neonatal neurological development, and I think we have to be cognizant of that fact. Now, just because she's had a preterm birth, does she also fall into the category of women who can have adverse outcomes going forward, Latha?
Probably yes, even if you did not have any other background risk. Probably stress is one of the main factors which can bring on preterm births. Though there are not many studies, probably it's worth watching and probably studying these women.
And what about the baby?
Baby, again, preterm deliveries, it has its own problems, short-term and long-term, neurodevelopmental delays, etc. We have to be worried about. Giving magnesium sulfate as a neuroprotector, I think it's important that we use magnesium sulfate at least up to 34 weeks. Yeah, if not up to 36 weeks. So that's one of the things that we could use as obstetricians, but we cannot sort of predict the neurodevelopmental outcome, unfortunately.
So there is some evidence about the long-term effects of prematurity on the fetus, on the neonate. And as I said, dexamethasone is something that we need to be cautious of, effective as it is in the prevention of respiratory distress and other problems. So, it has been an extremely wonderful panel. And before I ask for a quick comment from each of you, I just wanted to say that the focus was essentially to bring on focus, the panel, that any adverse pregnancy outcome does increase the chance of NCD going forward, not just for the mother, but also for the baby, especially in the context of gestational diabetes. And lifetime intervention and improvement of risk is what needs to be emphasized. And as they say, knowledge is power. And it is important for us as obstetricians first to assimilate this knowledge, and only then will we be able to transfer this knowledge to the woman, because at least in the context of GDM, I've seen enough number of women who because their sugars are normal, think that they don't have an issue. And because diabetes is so common in India, I feel at one level, people just don't take gestational diabetes seriously. So we do have to transfer this knowledge to the woman so that we can get excellent outcomes going forward. So maybe some...
Uma, just one question to Dr. Hema.
Sure.
Could we track all these problems to MCTS, that is the maternal and child tracking system, and send repeated SMS for them to get checked? Whether that would have some impact is a thing to be seen, probably, Hema.
Yeah, there's always a dream for us to connect maternal health and the NCD ministry together, and we have them for all our meetings. But again, as has been oftentimes discussed, the implementation, that is where we are. So they're saying first you do your 100% universal screening, madam, and then you come. First you bring your data on the table on metformin and long term, and then you come and speak. So each time, and then many of our peer group members, each one of us in the audience here who has the opportunity to check for these adversities in pregnancy, please do so. And please, in your own capacity, try and map them for long term. And let's, as Latha said, pull in our data and get somewhere, even from within our own community, so that we will have the strength to put this on the table and tell our ministry that here is where it is, this is where it's going, and therefore we need your help to collage the data for the entire country. So somewhere we have to begin, and thank you for that, Dr. Latha, as always. The huge challenges that we are facing all the time, but it's like we will get round, because more and more of our obstetric community are definitely sensitized to the fact that it all begins in utero. And the short term, long term, out of sight, out of mind is no longer their thinking. They want to track this, and we want to disseminate this in as many as in the peer group possible, because we as obstetricians feel that not only for 2 lives, but for 2 generations or more, we are responsible. So with that responsible statement, I and myself will promise to come back again, because there are several questions on 3 drugs. One is metformin, one is aspirin, the other one is low molecular weight heparin. loads of questions on that. So we will be running a session like an FAQ on three of these, because we need the experts like yourselves to clarify. Because one question that, oh, if GDM and hypertensive disorders are going to be hand in glove, can we then give aspirin to all our GDM patients to prevent hypertension? Maninder says, this webinar has given food for thought. And if others have commented like this, it's really a serious food for thought, I must say. Because yes, the innovative thinking is there, but we have to put it in perspective. We have to see again the benefits versus risks. We have to see what is feasible and implementable. And most of all, we have to gather the data, audit it, learn our lessons, make course corrections, get moving to do one step at a time, but the best we can. Myself, we were just on the verge, we were just a week away from this webinar. We had second thoughts about, postponing it another week or 10 days. I said, no, Ma, just let's get the group together. Let's just brainstorm, because this is the beginning. And again, we have many, many requests from the audience that we must get together to deliberate more. And on behalf of Uma, myself, and all the organizations which have brought us together this fine afternoon and added so much value to the way we have spent our time this afternoon. One last time, I'll let Uma have the last word, and on my own behalf, thank you very, very much. Namaste.
Thank you very much, Hema. I just wanted to thank the audience who have signed in large numbers. And we will try and see if some of the more simple questions can be answered and in response. And as Hema says, we'll be happy to come back for another forum. I'd like to acknowledge ICOG and thank them for giving 1 credit point for this CME. And we will have those certificates sent out as well to your email. And I want to acknowledge and thank Sun Pharma for their support in bringing this program together, and Science Integra for providing the logistic support and the platform, and for the seamless execution and coordination that they have done for us.
The Sun Pharma Spectra division, so it's really a whole spectrum of spectacular faculty and a great audience covering a whole spectrum of deliberations. Thank you so very much.
And thanks again to all of you for making your time and for some very, very good deliberation points. Thanks very much.
Thank you. And don't underestimate the power of obstetricians, especially in India. And I think you guys need to, amazing energy. I think you guys need to carry it forward. I think you underestimate the influence you have on the mothers and their long-term health. Thank you. Really enjoyed it.
Very much. Can I just say,
Shilpa, thank you.
Yes, David.
Just in Australia, people were talking about manels, which are panels with too many men on them. And I'm glad to see that at least in India, you've got a very appropriate representation of females in the obstetric and nutritional spheres. Congratulations. I can't help that I'm a man, but I appreciate that there's a strong representation of ladies on the panel.
Excellent.
Thank you. So we are moving towards SDG goal of gender equity, David.
Right.
SDG 3 and SDG 4 and 5. We are on the run. Thank you so much.
Well done. Thank you.
Thank you so much. Thanks, everyone. Thanks, Hema.
Thank you.
Thanks so much.
Bye.
Pleasure.
Thank you, doctors. Thank you so much for your time.